So, good evening, everybody. It's my great pleasure to introduce today's speaker, Dr. David Rosen. Dr. Rosen joined Cleveland Clinic in 2018 after completing a fellowship in colon and rectal surgery at Washington University in St. Louis, and probably more importantly, his general surgery residency at the University of Southern California. While at USC, Dr. Rosen markedly established the record for fastest time to the cecum, according to Professor Adrian Ortega, a record I myself could never quite beat, but I'm still confirming it wasn't on a patient with a Deloyers. Throughout his career, Dr. Rosen has developed a deep interest in all aspects of colorectal surgery, but notably, his expertise in the management of diverticulitis, both in its medical and surgical approaches, makes him a perfect speaker for today's discussion. In recognition of his contributions, Dr. Rosen was named section head of the Division of Colon and Rectal Surgery at Cleveland Clinic Fairview Hospital in 2022, further solidifying his role as a key figure in advancing colorectal care. So today he will be sharing his insights on diverticulitis, a condition that continues to challenge us in both acute and chronic settings. So please join me in welcoming Dr. David Rosen.
Thank you, Jordan, for that very kind and generous introduction. It was not a patient with a Deloyers, but it was an ileorectal. So it was even easier than you. No, I'm just kidding. But that's funny that Dr. Ortega talks about that. So as you mentioned, we're going to be talking about diverticulitis today, which is a disease that continues to vex us all. There's probably few diseases, and especially in colon rectal surgery, that we operate on and take care of so much, and we still know so little or confused about the etiology, what causes it, and how to prevent it, and things like that. So it's quite interesting. We know how to fix it once it happens, but how to prevent it continues to vex us. So we're going to start off with some getting into talking about the epidemiology and what diverticulitis and diverticulosis is. So that'll be somewhat as a basic review. And then we'll get in what I really am going to focus a lot on is some of the challenges and controversies associated with this disease process. So diverticular disease, it's important to remember, is really a spectrum of a disease process. They're both anatomic and physiologic changes. And what happens is the problem becomes not with the development of diverticulosis, but when that diverticulosis causes problems with inflammation, microperforation, things like that, and you get to diverticulitis. It can become with a lot of different symptoms and presentations. As we know, most commonly happens in the sigmoid colon, but it can occur in any part of the colon. And most of our disease process recommendations are based on sigmoid diverticulitis, since that's obviously where we have the most volume. So this is an old slide, from a paper from Dr. Etzione's kind of landmark paper in 2009 that shows the rising incidence of diverticular disease. But this trend that you see here has continued. So you have over 70% of people in the world have diverticular disease, or excuse me, I'm talking about the United States. Over 70% of patients in the US have diverticular disease by age 70. 10 to 25% of those patients develop diverticulitis. And you see similar trends of this in other industrialized countries. And we're seeing increased rates of admissions, especially in younger patients. So of those 70% that develop diverticulitis, 10 to 20% develop symptoms. 10 to 20% of those require hospitalization. And then of those hospitalized, 20 to 50% require surgery. So overall, less than 1% of patients with diverticular disease will require surgery. And that speaks more to the prevalence, the large prevalence of diverticulosis, and how most times it doesn't bother people. A lot of times after you do a colonoscopy, if you mention it on a report and a patient sees it, they'll ask, well, what do I do about this? And the answer is not really anything. We'll talk about some things that we think might help, but there's not a whole lot that needs to be done. So the rates of cases, of the incidence of cases, I should say, of diverticulitis are, as we talked about, are increasing, especially in younger patients. But the number of times we're operating on it are decreasing. This has really changed over the years to a non-operative disease process by and large. Okay, so what causes it? We don't really know. There's more and more research being done that shows there's some genetic associations. Probably something to do with the microbiome, as we're learning more and more, can have a relation. But we do know that smoking, you're 3 times more likely to have complications from it. If you're drinking alcohol, you have 2 to 3 times more complications. And is that from the alcohol, or do alcoholics just have worse dietary patterns that may be contributed? The thing that every patient will ask you about is about nuts and seeds and popcorn, the old things that we used to think about. And the data we have actually shows that there is no increase in formation of diverticula or complications with those things. Now, I'll admit that patients come to see me and I tell them this, and a lot of times patients have these preformed ideas that it's 100% the one thing they're eating that is causing the problem. And it's not really worth it, I think, to talk them out of it or try to convince them what it is. What I tell everyone, I say this about kind of all disease processes to patients, whether I'm talking about diverticular disease, IBD, cancer, et cetera. A lot of patients have questions about nutrition and what to eat. And I think the important thing, what I tell every individual patient, is what matters most is your own personal body. And you're going to know better than me giving you some list as to what to have or avoid, or what irritates your body. So you just start keeping, I tell everybody to keep a food diary. And if you start noticing a trend of when you start having issues after you eat certain types of things, try to put that together and maybe eliminate that one thing and see if that does anything. And that's kind of where I try to focus on these patients. All right, so brief review on the pathophysiology of this. The colonic diverticula are typically false, meaning that they're not full thickness diverticula. They can be they're formed, what you find in the diverticula, you get increased elastin deposition and collagen cross-linking. Diverticular disease increases. We know there's things that increase, and some of this is similar to a lot of the colonic disease stuff we see, such as cancer and stuff like that. So increase in red meat consumption, increase in dietary fats, decreased amount of fiber or fruits and vegetables, more sedentary lifestyle. As you get older, more likely to get diverticula, obesity associated with this. And smoking, there's more risk of complications, but the development is kind of sideways, and same with NSAID use. So what I tell everybody is, as you can see on these things, you just got to live a generally healthy lifestyle, right? Eat well, exercise, all your vices, do them in moderation. And that's pretty much how you're going to deal with a lot of GI diseases and colonic diseases in particular. So you get high intraluminal pressures with the segmentation that happens in the colon. And so what happens is over time, you get a thickened muscular wall. The colon acts kind of as individual compartments as it peristalsis, and you get this high pressure push against the colon wall, which, as you can see in this picture, kind of pushes out the false diverticula, or the false diverticula, and that's where these start to form. Where this happens, it occurs at the muscular defects where the blood vessels penetrate the wall. And again, it's only the mucosa that's herniating, so it's similar to like a pulsion or acquired diverticula. And because the sigmoid colon is the narrowest part of the colon with the highest pressure, that's why this tends to be the area that these form the most. Now, the fiber bulks we always talk about fiber, right? Like if anyone comes in, anything that we have to do, usually, colonic disease, whatever it is, it doesn't matter if it's anal rectal disease, colon cancer, diverticula, it's always eat more fiber, right? If they're already eating fiber, oh, you're not eating enough, you need to eat more, or you're eating the wrong type, right? And so we do know that fiber, the theory as to why fiber would help in this disease process is that it'll bulk the stool, which will then create a larger lumen over time, less pressure, less segmentation, thought to be less diverticula and less complications. So that's the thought as to why fiber does. If it really works, we don't really know. We don't have good data that says that, but that's the thought process. And we know that it's good for our GI health. It feeds the good bacteria inside our colon. So it's certainly not going to hurt in this disease process. Though interestingly, we do tell patients after an episode to try to avoid that. We think it might be irritating the first couple of weeks and then get back on the fiber. All right, so you can here see just a little scheme where you can see the areas where those blood vessels are coming in and penetrating the wall and those gaps, and that's kind of where the gaps in those vasorecta. That's often where these the diverticula will form in between those tinea. Okay, so diverticulosis is by all means typically asymptomatic. But that one thing you do see is you can get bleeding, and it can be a massive GI bleeding complication that typically is self-resolving, but not always. So 80 to 90% of patients with diverticulosis will have no symptoms ever. So diverticulitis is when it becomes symptomatic. And it's, there's a couple differing theories as to what is actually happening with diverticulitis. Some people will say, and I subscribe to this theory too, I do think that every time there's an episode of diverticulitis, there's some kind of microperforation, which then has varying degrees of inflammation and infection, depending on how quickly the body can seal that hole, right? The body recognizes that there's a hole in the colon and that's not a good thing. And then what the body will do is they'll try to use whatever it can to seal off that hole, right? Whether it's a surrounding organ, whether it's epiploic or fat, it'll try to shut that hole because the body recognizes it doesn't want stool and bacteria kind of swimming around in the intraperitoneal cavity. So other people, there is a theory too that especially uncomplicated diverticulitis, which we'll get to defining here in a moment, is really just from a fecalith could just be getting stuck and causing inflammation, and that inflammation irritation causes this full thickness inflammatory reaction. As we don't know exactly, but I think most people, and myself included, believe more in the microperforation kind of theory. All right, so the symptoms most commonly are left lower quadrant, but it really can kind of occur anywhere, especially in the lower abdomen. You can have right lower quadrant pains. The sigmoid colon can be floppy and shift over. There can be irritation surrounding small bowel, or if the appendix can be drawn into a phlegmon involved, a patient sometimes present with right lower quadrant pain. You can have constant pain that can radiate to the back, flank, or groin. Patients can have fever, usually nausea and vomiting. You can have it, but a little bit less common, so similar with bleeding. And if there's irritation on the bladder, or if it's developed a colovesical fistula, you can have dysuria, urgency, or pneumaturia, or fecal uria. And similarly, if you develop a colovaginal fistula, you have gas or stool by way of the vagina. Okay, so now we're going to define, that's kind of the boring basic stuff out of the way. Now the real question, what you guys all want to know and need to know is most important, is how do I treat it? What do I need to do? And then after that, we'll get to what are some of the controversies associated with this disease process. So we divide diverticulitis into uncomplicated and complicated. And that's important because that's really, whenever I see a patient, that's where I'm getting my mindset. That's not I'm getting the frame of mind in first is this uncomplicated or is this complicated? That's going to sort of take me down two different paths as to how I'm going to treat them. So uncomplicated diverticulitis, as it sounds, there's no complication associated with that diverticulitis, meaning you can have CT findings of stranding or thickened colon in the setting of diverticular disease. This can oftentimes be empirically treated as an outpatient if it's a mild symptom and a patient has a repetitive history without a CT scan. But typically most things are done with a CT scan. Complicated diverticulitis, as it sounds, you have a complication. Well, that could be a pericolonic abscess, a free perforation, or seeing gas on CT. You could develop a complication such as some kind of fistula, colovesical, colonenteric, colovaginal, colocutaneous, or a longer term from repetitive episode of diverticulitis, you can get a colonic stricture or stenosis, and that's usually a more delayed complication. I think what a lot of us argue about is when you see, and we often see this, sigmoid diverticulitis with a couple blips of air just right around the colon, or is that uncomplicated or is that a complication? Or even what if you see it's just some inflammation around the colon, but you see some free air up under the diaphragm, what is that? Is that uncomplicated or complicated? And I think you can make argument either way. Personally, I tend to treat those a little bit more like uncomplicated. When it gets up to the diaphragm, though, I will admit, I tend to be like, maybe this is a little bit more of a microperforation than before. Do I need to treat this a little bit more aggressively or be more in a complicated mindset? And that I think every individual provider is different. All right, so how are we going to diagnose this? The CT scan is really your test of choice because it stratifies uncomplicated and complicated. It provides information on adjacent structures. And if there's an abscess, it'll allow an early CT-guided drainage of that abscess when possible. So, and the thing is, the thing you have to be careful about is anytime, as colorectal surgeons, we typically get consulted for diverticulitis from the emergency department. Usually by that time, the patient has had a CT scan. And usually that has already been done. I will caution to say that there are patients who will have, I have that get recurrent uncomplicated diverticulitis every 6 or 12 months. And the symptoms are always the same. And they've learned now at this time, if it is exactly the same, you have to really know your patients and know if this is the right patient. Then sometimes I'm okay foregoing and CT scan and watching. If they know what it is, seems exactly the same. But for the most part, to be certain, the test of choice here is a CT scan. The other thing the CT scan can help indicate is the Hinchey classification. Now, it can't tell you 100% to Hinchey 3 and 4, which we'll get to in a second, because the Hinchey classification was really developed as a surgical classification. So there's 4 stages to the Hinchey stage, and this is kind of where we've adopted and kind of modified it to the current state that the Hinchey classification is. Hinchey stage 1 is a localized abscess, and actually that's now been broken down into 1A and 1B, with 1A just being a phlegmon or inflammation around the colon, and 1B being an actual abscess, a pericolonic abscess. Hinchey stage 2 is when you have a pelvic or retroperitoneal abscess, so it's a little bit further away. It's not directly adjacent to the inflamed part of the colon. And stage 3 and 4 are obviously some that are diagnosed in the operating room, so with purulent and feculent peritonitis. And you can see here a little classification of the Hinchey score 1, 2, 3, and 4. You see a localized abscess, then you have a large abscess in Hinchey 2 extending down to the pelvis. Hinchey 3, you can see what they're trying to show there is, pus throughout the abdomen. And Hinchey 4, that nice little explosion they have there with feculent peritonitis is what they're documenting. So, all right, here's a CT scan of what we've all kind of seen. Uncomplicated diverticulitis. Looks like you have a thickened bowel wall there. You can see some diverticula and the fascial infiltration in the mesentery. Inflammation, no abscess, no complication. This is uncomplicated diverticulitis. Similarly here, I think that air in this image is within diverticula, but maybe there's a little bit of blips. It's tough to tell. That could be some small air just outside the colon, but this is uncomplicated diverticulitis. It's important to remember that colonoscopy should not be performed in your acute attack because it might increase your risk of perforation and you have a less chance of a completion rate. But you do want to do it to confer the diagnosis and rule out cancer. Usually we say you want to wait about 6 to 8 weeks till that active episode resolves. Now, I will say now, as data comes out and we know more, really the risk of having a cancer or missed cancer where instead of diverticulitis, much higher for complicated than uncomplicated. So for me, you have to decide, well, how recent is recent enough for their most recent colonoscopy? So for me, for someone who has had uncomplicated diverticulitis, and I will definitely within 1 year is fine for me. I'll even go up sometimes to 2 or 3 years if they're a repetitive customer and their colonoscopy was a great prep, completely clean. Then I think that's probably okay. Pushing 2 to 3, then usually I'll say, okay, you need another colonoscopy. Complicated diverticulitis for me personally has to be within a year. And that's kind of just what how I've extrapolated from the literature in terms of how comfortable I am with how recent their colonoscopy can be. And the other thing that the benefit is that you do is if you have you can rule out that there's no other big polyps or anything elsewhere that you might need to deal with, especially if you're planning a surgical resection. Now, the other thing I will say is if someone has a really bad episode, like complicated episode, multiple abscesses, multiple drains, and you kind of just know from how bad things are that there's almost no chance you're going to be able to complete that colonoscopy. In those patients, sometimes I will forego it if I think that it's not going to be in the cards. I do have a nice schedule where I can schedule patients. I have my endo day is right before one of my OR days, so I can try to schedule people for a colonoscopy on Tuesday with a plan to do surgery on Wednesday with a single bowel prep. But there are times where I can just tell that it's not going to happen and don't do the colonoscopy. But for the most part, you definitely want to try to. All right, here's the obligatory picture of what diverticuli look like on a colonoscopy. Okay, so who do you get in an elective resection, right? We always try to get all these patients, whether it's uncomplicated or complicated, into initially managed non-operatively or managed conservatively and non-operatively. The reason for that is we know that if we get them, even if we see a patient like this patient is going to need surgery, if you can get them to an elective setting, it increases your risk or increases your likelihood of doing it in a minimally invasive fashion, step one. Step two, it increases your likelihood of avoiding an ostomy. Two things that are better for both the patient and the surgeon. It's a win-win for everybody. So that's really what you're striving for. So now we're talking about uncomplicated diverticulitis for the moment. So in uncomplicated diverticulitis, who gets an elective resection? Well, when you decide that, I think what you need to keep in mind is some of the stats. And so we know that 10 to 35% of patients will have a recurrence after their first uncomplicated episode. Only 3 or 5% 3 to 5% will have a complicated episode after their initial uncomplicated episode. This is what we always talk about. The first is the worst type of episode, which happens for most patients. Not all, but most of them seem to subscribe to this. And I would say anecdotally, probably a little bit higher than 3 to 5% in terms of the first being the worst, but I wouldn't say probably any much higher than 10%. And I do think as time goes on, the episodes tend to not be as harsh or severe as the first one. So usually if you can get them through the first one, that is typically the worst. What all patients want is to not have a bag, right? If they're dealing with diverticulitis. That's always a big concern for patients. But what I caution my patients is that as you go on, your risk of having a giant episode with a free perforation goes down with each episode. You can see here, free perforation rate, the first time is 25%, then 12%, 6%, 1%. So because you've had it once, if it's been uncomplicated, most patients tend to stay uncomplicated. And so you can assure them that actually, and we'll talk about this in a little bit, usually their risk of surgery of surgery causing a ostomy bag is higher than their risk of it happening organically with just a huge episode and a perforation. So surgery for a theoretical risk of having an ostomy bag for uncomplicated diverticulitis is probably not a good reason to do it. It's probably unwarranted. So here we go. First is the worst. If the diverticulitis is usually not progressing, and most emergent surgeries are performed during the index episode, and then less than 5% after an uncomplicated attack will develop a complicated recurrence. So it's important for patients to know that when deciding do they want surgery. 25 to 12% will experience more than one recurrence, more than one occurrence. 25% of those recurrence patients will have a second recurrence. And as you go on, those rates will go up. There are patients that we all have that get these kind of recurrent every 6 to 12 months attacks, uncomplicated, and they just kind of deal with it. So this was a good study out of DCR in 2020 that talked about like, well, okay, how many patients are we going to stave a bag if we do a resection of diverticulitis? So after their first episode of uncomplicated diverticulitis. So what they found when they looked at it is that the estimated risk of needing emergency surgery with a stoma formation is 1 in 2,000 patient years of follow-up. Now, even if you don't know statistics to really understand what 1 in 2,000 patient years means, that's a big number. So you can probably gather that that's a lot of years to be saving one patient a bag. And so that's kind of where I was getting to the point at. If there's, if you're doing it just to prevent a bag, probably not a good reason for uncomplicated patient on diverticulitis. And here's the breakdown for people like me that don't understand statistics to say that 18 patients would need to undergo elective colectomy to prevent 1 emergency surgery for diverticulitis. So that's a lot. 18 is a lot, right? And so you figure if the national average on a leak rate is, say, 3 to 5%, right? I mean, 5% just makes the math a little bit easier. Then that's 1 in 20 would have an anastomotic leak. And then that higher than that they would have some type of complication or perioperative issue. And so you're putting patients through some risk that they wouldn't have if they didn't have surgery. So something to think about when you're deciding who's going to need surgery. So here's another study out of the Annals of Surgery, retrospective review of 12,000 patients treated inpatient with their index episode of uncomplicated diverticulitis. They compare the rates of recurrent diverticulitis and of an ostomy treated with and without surgery. And this is a very interesting study. What they found is that the surgery reduced recurrence, but the surgery group actually didn't reduce the risk of stomas compared to the non-surgical group. And the reason for that is surgical complications, right? Either the tissues aren't good when you aren't appropriate for a primary anastomosis without a bag when you're in there, or they have a postoperative leak or something that requires a reoperation and a stoma. And here's the table kind of looking at patients who are placed in this medical therapy group versus an elective surgery group and their ostomy rate. You can see they're down in the bottom right corner, 2.3% is their ostomy rate in medical therapy and 1.8%. That's at 5 years. And that goes down because some of those elective surgery patients end up getting reduced. That's why you see at 1 year, 4% starts going down as you go down that column. But on the left side of that table, you can clearly see the recurrence rate in the elective surgery group is much less. So no doubt about that. Okay, so what's the point here? Like, I know I've confused you with all these random studies and data, but let's sum it all together. And I don't mean to sound wishy-washy, but the decision needs to be individualized. First is the worst. It's important to remember and point that out to patients. The disease, when they have an uncomplicated attack, has declared itself as most likely being committed to being uncomplicated. We used to have a number of episodes or an age that we would say sometimes was after their second episode, after your third episode, or if you're under 40, then you should get surgery for sure at your first episode of diverticulitis. But we found that to not be necessary and not be true. So young age as a recommendation for surgery alone is not recommended. And don't operate to just prevent a hypothetical future stoma. And like I said, not based on the preset number of attacks. What I do when I talk to my patients is I really say, okay, the reason to do surgery is how much is this impacting your quality of life? Are the attacks becoming so frequent that you can't go anywhere? You're worried about leaving anywhere near a bathroom. The symptoms aren't really going away in between those episodes. You have these smoldering, persistent abdominal pain. They're completely disabling. You're missing work. You're having repeated hospitalization, and it's becoming really a financial burden. Those are all good reasons to have surgery for uncomplicated diverticulitis. We talk about people who are traveling all the time and are worried about having repeated episodes. Might be a good, decent reason to have surgery for uncomplicated diverticulitis. But really, it's based on how much is this affecting their quality of life. And what I tell people is, for the uncertain patient, when I talk to them about this data, it's okay to wait. You're probably going to be just fine. And when you're ready, when you've had enough of this, it's really bothering you, then we'll do surgery. And the other thing I want to remind them of is surgery really works. The recurrence rate of having another episode of diverticulitis after surgery for sigmoid diverticulitis is about 5%. The main predictor of that is if they have a colocolonic anastomosis. So it's really important to make sure you get down to where the tinea splay out, down onto the upper rectum for your distal margin, because that's really where patients will have recurrent, or the majority of these recurrences will occur. The other thing that's really positive for these patients is when we've looked at quality of life, it's improved significantly after surgery. A lot of times patients don't realize until after surgery how sick they've been and how many problems they've had until, at their 3-month follow-up, and they're saying, oh my goodness, I can't believe I was living like this all these years. I feel amazing. All right, so that's uncomplicated diverticulitis. Now we're going to shift gears and talk about complicated diverticulitis. So complicated diverticulitis, similar to uncomplicated, in the short term, when they come into the hospital, we try to manage non-operatively, conservatively. That involves usually, bowel rest, IV antibiotics. If they have an abscess that is percutaneously drainable with our IR colleagues, that's a great method to try to do that. Usually we talk about abscesses at least 3 centimeters or bigger, need to be drained if they are accessible. But again, for the same reasons as uncomplicated, in terms of greater chance of minimally invasive surgery and greater chance of avoiding a stoma, we try not to operate in the acute setting if we don't have to. Now, if a patient is peritonitic, hemodynamically unstable, septic shock, then of course it's a different situation. They need to go to the operating room. So say you get a patient through and they have a percutaneous drain place for a complicated diverticulitis with abscess. After abscess drainage, probably about 40% of these patients develop a recurrence while awaiting a resection. 51% of patients who have a mesocolic abscess and 71% of pelvic abscesses eventually require surgery, so quite high. A little bit older data from about 10 years ago. Another paper out of DCR from 10 years ago showed that 28% of recurrence rate after non-operative management of diverticulitis with abscess. So probably somewhere in that 30 to 40% rate. Interestingly, 1% of these patients in this paper presented with a free perforation requiring emergency surgery. In Dr. Regenbogen's paper back here, a little bit higher rate than that. But in this paper, only 1% of patients had a big free perforation. So lending more credence to the thought that, okay, maybe it's safe to try to get these patients through with a non-operative management initially, if we're able to stabilize them and get any of the source control and your typical septic considerations. So fistula is another. So abscesses are one complication, fistula are another. The way this kind of presents is you get diverticulitis, microperforation, abscess forms. The abscess kind of ruptures and can kind of invade in and erode into surrounding structures. Colovesical fistula is the most common area, and usually it happens to the dome of the bladder, because that's kind of right where the sigmoid colon is sitting. Different people have different practices in terms of a cystoscopy. I typically do not routinely perform a cystoscopy if the story seems like diverticulitis. It's something that's weird, and then I might think about a colonoscopy and cystoscopy, but it's not a routine thing that I do. What's interesting is you don't need to necessarily repair the bladder, these fistulas, right? Typically, these colovesical fistulas are very small and diagnosed by CT scan, seeing air within the bladder. And so what you find is that when you usually these things get kind of like finger fractured off or fractured off, and you don't ever really see a hole. If you see a hole, obviously you have to fix it. Or if the patient's had a history of pelvic radiation, I would recommend it fixing. But if it's something that you kind of divide, or you're doing it, minimally invasive, you come right across the fistula, and you're not seeing any hole. A lot of people like to blow up the bladder by inserting fluid through the Foley catheter. And if you're not seeing a leak, there's nothing really you need to repair. That being said, again, if it's radiated or there's a hole, then you need to repair it. It's important to remember absorbable sutures. Usually I do 3/0 vicryl because you don't want to cause any bladder stones. This colovesical fistulas are less common in females due to the uterine protection, and colovaginal fistulas are the next most common fistula, 25% of diverticular fistula that are seen in women after hysterectomy. And then thirdly, colocutaneous fistulas. All right, so here's what I was talking about, your history of diverticulitis. They got pneumatoria fecal area, CT scan showing air in the bladder. That's a colovesical fistula, sort of pathognomonic. So okay, so now, what do we do then for these patients that have complicated diverticulitis? So if they have a complication such as a fistula, an obstruction, or a stricture, there's not really much of a choice unless they're so sick, they're surgically prohibitive. They need an elective resection. What about for an abscess? Well, typically, and this is what it says in our ASCRS, practice parameters, is that an elective resection should typically be considered after non-operative treatment of a diverticular abscess. Again, a CT-guided draining is the initial recommendation for patients who are clinically stable for abscess 3 centimeters in size or greater. But what's important to note too is that not all abscesses are created equal. So if you have a tiny 1 centimeter abscess that it's really tough, like, is that even an abscess? Is the radiologist overcalling it? Those types of things are not necessary. Those aren't patients that I'll say you have to have surgery. If they have a big pelvic abscess or anything that requires a drain, I will tell patients I will recommend surgery. But if it's someone who's their first episode, they have a smaller abscess, then they're really hesitant to undergo surgery, or even if they're looking for my advice, I tell them you don't necessarily have to, because the first is the worst concept, and the data we have on complicated diverticulitis seems to apply to complicated diverticulitis as well. And so it's reasonable to hold off and just try to see what happens. All right, so we've talked about uncomplicated diverticulitis, when to operate. We talked about complicated diverticulitis, when to operate. Those are kind of the pathways I walk down when I'm thinking about patients who needs surgery. We kind of glossed over a little bit patients that need surgery emergently, but obviously those are the patients that, like I said, hemodynamically unstable, peritonitis, really sick. Those are patients that need surgery on their index presentation. So we're going to talk a little bit about some of the controversies now that we face in diverticulitis. So first thing is, does uncomplicated diverticulitis need antibiotics? And so the first study that we kind of looked at this is the AVOD study out of Sweden. You'll notice that all these, a lot of these trials are European. So the US is not as good as our European colleagues in performing some of these trials. But we're trying to change that. But the AVOD study was a randomized controlled trial. So it was a randomized trial, 623 patients, done in Sweden. And what they were able to look at is they had patients, they actually admitted these patients and they saw, okay, antibiotics or not, how do these patients do? And so with or without antibiotics, there was no difference in pain, tenderness, or fever curves. There's no difference in recurrent rate at 1 year. So that was in 2012 in the British Journal of Surgery. The Diabolo trial similarly was this is a Dutch trial, randomized controlled trial. At 528 patients. And interestingly, it was uncomplicated, but they included Hinchey 1B. So those with pericolonic abscesses, and those were 8% of their patient population. And what they found is even when they included those patients with complicated diverticulitis, those Hinchey 1B, and granted, there's only 8% of the sample size, but they looked and they compared again antibiotics versus no antibiotics. They found no difference in recovery time, development of complicated diverticulitis, ongoing diverticulitis, needing surgery, readmission, adverse events, or mortality. And so then what we got the most recent is the Dynamo trial. So this is a trial out of Spain, a prospective non-inferiority randomized controlled trial. So if you had CT proven uncomplicated diverticulitis seen in the emergency department, and then they were randomized to a discharge home with 7 days of Augmentin, ibuprofen, and Tylenol versus ibuprofen and Tylenol. They kind of cherry picked their patients a little bit. So these patients included in this trial could have a maximum of one of these following criteria: fever greater than 37.9, white count greater than 12, heart rate greater than 90, respiratory rate greater than 20, or a CRP greater than 15. So these are the least sick patients that we see. And they had no difference in rates of return to the ER or admission, and absolutely no one needed an emergency surgery. So I would say that, so oftentimes as colorectal surgeons, once we get called about a patient that has come to the ER, usually they're a little bit more sick, I'd say, than what the patient population described in this Dynamo trial. But even looking at previously at the AVA and the Diabolo studies, there is really good evidence to say that uncomplicated diverticulitis, and maybe even some of our complicated or less sick complicated diverticulitis, doesn't need antibiotics. And I agree with this. I think from a logistical and physiologic standpoint, it makes sense, because I don't necessarily think the antibiotics are treating any of the diverticulitis itself. I think the body is taking care of that. I think what the antibiotics help with is the septic complications and the cytokines that are traveling through and causing those septic responses. And I think that's kind of what the antibiotics help with. And so I think the body's able to deal with most of this on its own. Now, that being said, it's really hard, I think, for all of us in the States to not give these patients antibiotics, right? And they say, oh, all right, maybe they got admitted into medicine without you knowing, you got called about, and all right, just send them home with a week antibiotics. Or even I'll have patients, I'll say, this patient can go home, she does not need antibiotics. And then maybe the medicine team is uncomfortable with that decision. And so I think we really have to work to try to follow the lead of our European colleagues to stop giving these patients antibiotics. Now, if they seem to be a sicker, uncomplicated diverticulitis, I think that's a little bit different situation, right? They come in with a white count of 20 and fevers and they're tachycardic. That's not the patient that I will be sending home with antibiotics. I'll be admitting that patient, observing them. But a patient who comes in with maybe a mild leukocytosis, just kind of uncomfortable but doing okay, if they're a reliable patient, very reasonable. Probably what we should be doing is sending those patients home, not admitting them, and not giving them antibiotics. All right, next controversy I want to talk about is if you do have to operate emergently or urgently in the OR, what type of operation do you do? Historically, all these patients would, if they need emergent surgery, they would get a Hartmann's procedure, especially if we're talking about Hinchey 3 or 4 diverticulitis. Someone with smoldering diverticulitis that, Hinchey 1 or 2 is just not getting better and they end up needing surgery. I think, nowadays, I think doing a surgical resection, my practice is as long as they're, not malnourished, don't have risk factors, I think doing a surgical resection with a primary anastomosis and no ostomy is totally appropriate in those patients. Hinchey 1 or 2 are just, not getting better. Hinchey 3 or 4 with a widespread infectious process, different story. So that's what we're going to be talking about here, is talking about Hinchey 3 and 4 and some studies associated with that. So the Swiss trial was 62 patients with Hinchey 3 or 4. All these patients had primary anastomoses, all patients that had a primary anastomosis had a diverting loop ileostomy. So patients were randomized to Hartmann's procedure versus primary anastomosis with a diverting loop ileostomy. And looking at these patients, they had equivalent overall complication rate, 80 versus 84%, equivalent mortality rate. And what most of these studies show, and what they showed here in this paper back in 2012 at Annals Surgery, is you have a much better stoma reversal rate if you do a primary anastomosis with a diverting loop ileostomy, 90 versus 50%. So a lot of those patients with the Hartmann's, maybe whoever did it didn't feel comfortable reversing them, or the patient just decided to live with it. But there obviously is going to be some complications associated with that down the line at some point, whether it's issues with managing a stoma or hernia, things like that. So that's what is thought to be a win about doing the primary anastomosis with a diverting loop ileostomy. Now, and this was also associated with reduced hospital length of stay and costs. Now, it is important to know your patient, though, if you are going, and if it's someone who is just floridly incontinent and is having a miserable time with their colon and was thinking about, a bag then a Hartmann's might be appropriate, because then if you're someone that you think would need, or they're very sick, they're not doing well in the operating room, you need to just get out of the operating room. I still think a Hartmann's a good, safe operation. But for patients that are doing fine in the operating room and they're not someone that you would think would benefit from a permanent stoma, or your discussion with them beforehand doesn't seem to indicate that, then what this study showed, and I'll show you some more here, is that a primary anastomosis with a diverting loop ileostomy is what we should be doing. So the Diverti trial showed a similar thing. So 102 patients with Hinchey 3 and 4, their primary anastomosis group versus Hartmann's group, diversion in this study was optional. So 2/3 of the patients were diverted, but 1/3 of the patients were not diverted. And interestingly, no differences in mortality, no differences in morbidity. And again, a large difference in the stoma-free rate, with 65% of patients with a Hartmann's procedure no longer having a stoma, so 1/3 of patients still having a stoma, versus only 4% of patients with a primary anastomosis still had a stoma. So what does this look like in the operating room? So if you're doing it the way this was originally described by Lucas Stokey back in 2010, is that you do a segmental resection, you irrigate everything out, you got to mobilize the splenic flexure, and then you actually need to do an on-table lavage to clear this out, because these patients aren't going to be prepped, right? And so what you do for that, the way it's described, you can see in the picture, usually you insert some corrugated tubing distally. When I'm doing this, usually I'm using the ventilator corrugated tubing and secure it with some umbilical tape. And then usually I'm making an appendicostomy or a distal limb ileostomy. If they have their appendix, definitely appendicostomy is the way to go. Put a Foley in, and then you irrigate with 3 to 6 liters of warm saline. This is how you really make friends with your OR team, is they love doing this procedure with all the stool going everywhere. But you got to make sure it's secured going into a bucket off the table. But it's a challenge to do, and you really can only do it open. If you're trying to do a minimally invasive procedure, there's no good way to do this without spilling it everywhere. And then it's a nightmare. So now, and then you do your anastomosis. So I will say that when I do this procedure, so my go-to for this is I do a lot of these urgent cases with in a hand assist fashion. So I get the benefits of minimally invasive um, surgery, but able to use the hand, which helps with like finger fracture and breaking up some of these nasty diverticulitis. And I do not do the on-table lavage. So I will do a segmental resection with a primary anastomosis and a diverting loop ileostomy. And I will not do the on table lavage. And that's something people always worry about or wonder about. Well, is that really gonna? What about that column of stool you're leaving behind? And what I find is that in these patients, where you really get into problems is if you have someone who's obstructed and you have bowel prepped and they have this big thick liquid column of stool. These patients typically have more formed stool, which I've not found to be a problem. Usually the diverting loop ileostomy diverts everything away, and the stool just kind of sits there and stands there, but doesn't cause any issues with the anastomosis. So I don't worry at all about not doing this on-table lavage. Okay, now another controversy we'll talk about, laparoscopic lavage. So the concept was, when this first came out, is that laparoscopic lavage and a drain placement in patients with Hinchey 3 diverticulitis would be able to wash out all this infection, get some source control, avoid any urgent resection, reduce having to do a definitive stoma at the time of surgery, and speed up their recovery and get them ultimately to a more definitive surgery. And this had promising early results. So the first study here, so they had a prospective study of 100 patients who had what was described as perforated diverticulitis. They had 8 patients when they got in there that had feculent peritonitis, and those patients all got Hartmann's. You had 25 patients of those hundreds that actually, when they got in the OR, had Hinchey 1 or 2. So only 67, so 2/3 of the sample size had Hinchey 3 at exploration. They talked about an 89% success rate, only 2 abscesses and 1 reoperation after. Not bad. There were 3 deaths, 2 that were in immunocompromised patients, so 2 in renal transplant patients. So maybe they identified a cohort that this wasn't good for. And then what you have, the next trial that was looked at this was the ladies trial. And the ladies trial was a randomized controlled trial, 42 hospitals in Belgium, Italy, and the Netherlands. And they had 2 arms to this trial. They had a DIVA trial and a LOLA trial. The DIVA trial was looking at Hartmann's versus primary anastomosis, which we just talked about. And the LOLA trial was looking at lap lavage versus primary anastomosis plus or minus a diverting loop ileostomy. So in that LOLA arm, the primary endpoint was 12-month morbidity and mortality. They had 90 patients that were enrolled. And they actually ended the trial early for safety because they had a higher risk of complications, with 35% in the laparoscopic lavage group versus 18% in the primary anastomosis group. And that was predominantly due to repeat surgical intervention, although those patients did have similar mortality at 12 months. The Delala trial was a randomized controlled trial. It took place a little later. The paper was published in the Annals of Surgery in 2016. Randomized trial of lap lavage versus Hartmann's at 9 hospitals in Sweden and Denmark. They enrolled 83 patients with purulent peritonitis. They had no difference in morbidity or mortality at 30 days, and they concluded that laparoscopic lavage is feasible and safe. Finally, here, the Scandiv trial was a randomized controlled trial of 21 centers in Sweden and Norway, enrolled almost 200 patients looking at lap lavage versus resection. And they looked at their primary outcome was a 90-day severe complications. They didn't have difference in morbidity. They did have a higher reoperation rate in laparoscopic lavage. And this is the thing I think everybody worries about. There were 4 sigmoid cancers that were missed in that laparoscopic lavage group. And so they found that their findings did not support laparoscopic lavage for perforated diverticulitis. And in their 1-year follow-up trial, although there were no differences in morbidity and mortality, there were more unplanned operations in the laparoscopic lavage group, needing more reoperation rate down the road. And they did have a lower stoma rate in the laparoscopic lavage group, though those patients had the same quality of life. So in the short answer is that laparoscopic lavage has been looked at pretty extensively, and its role is probably very limited, if used at all. I do not use it at all in my practice. Last controversy we're going to talk about before open it up for any questions is immunosuppression and diverticulitis, and what to do in your patient that is immunosuppressed. So we know that immunosuppression affects wound healing and the ability to fight off sepsis. So that creates a real problem with this disease process, because they're going to have a harder problem fighting off diverticular infection, right, from if they get the disease process. But they're also going to have a harder time healing if you have to operate on them urgently, well, at all, but especially urgently. So with those 2 things competing, should we be more aggressive or less aggressive in treating these patients? So the first thing you have to think about, well, what is immunosuppressed? Because not all immunosuppression is the same. Is diabetes immunosuppressed? Sure, we know that it is in some regard. Steroids, how much is considered immunosuppressed? For how long? If it's just 5 milligrams of prednisone a day, that's a long-term thing. Is that immunosuppression? Or, we know from the Crohn's literature that no one should really be doing a primary anastomosis if people are on the equivalent of 20 milligrams of prednisone a day or greater. But what about below that? There still is some effect, obviously, those hemorrhoids. Poorly controlled HIV, solid organ transplant on immunosuppression, chemotherapy. Those are all things that could contribute to immunosuppression. So looking at papers on immunosuppression and diverticulitis, there's a few papers I kind of put together to summarize here. The epidemiology shows about 1% of immunocompromised patients get diverticulitis. The age or presentation and symptoms are similar to immunocompetent patients, but 40% of patients present with complicated disease versus less than 25% of immunocompetent patients. So these patients, unsurprisingly, due to the fact that they have immunosuppression, are presenting with more advanced or more severe disease. More than 30% of these patients require emergent surgery, and the mortality is higher. Some papers are suggesting the range of 20 to 40%, with more recent data to the low end of that range, probably about 20%. The mortality from complicated diverticulitis for immunosuppressed patients is as high as 20 to 25%, but it's less than 3% for immunocompetent patients. So these patients are having with complicated immunosuppressed patients with complicated diverticulitis have a real hard time dealing with this disease process. If you have complicated complicated diverticulitis that is managed conservatively in immunocompromised patients, the recurrence rate is very high, 46%. And 75% of those patients, those recurrences will require urgent surgery. So the conclusion from these papers here is that an interval colectomy should be recommended following conservative management of complicated disease in this patient population. That makes sense. If 3/4 of the patients are going to need urgent surgery, better to do it in elective fashion. Uncomplicated diverticulitis does appear to be safe to manage conservatively initially. Recurrence rate is as high as 20 to 25%. And the risk of a second recurrence after that first recurrence is 5%. So that seems to be more similar to immunocompetent patients. So I think you can individualize the decision for immunosuppressed patients depending on, is it something, can they come off their immunosuppression, how sick are they otherwise? So you can treat, I think, uncomplicated diverticulitis in immunocompromised patients similarly to immunocompetent patients and individualize that decision. So this paper here out of DCR in 2016 looked at 736 immunocompromised patients undergoing an elective colectomy. So we're reviewing this. I think is important to know, well, what is important surgical considerations, perioperative considerations for patients undergoing an elective surgery. So mortality in this group was 2%, morbidity of 25%, which is higher than a mortality of 0.4% and morbidity of 12% in immunocompetent patients. I think the most important thing to do is you got to know your medications, and check if it's a transplant patient, check with your transplant doc. They're always very helpful as to helping us with what are the wound healing complications of these medications. Sirolimus is the worst one. So if you have transplant patients on that, you really want to try to get them off that. And usually I've found in my experience, my transplant doctors are able to convert them to another immunosuppression medication and then get them ready for surgery. Steroids you got to get off as much as possible because we know those are really bad. Tacrolimus and mycophenolate are okay to continue, as are typically, as we know from the IBD literature, things like methotrexate and azathioprine and things like that if patients happen to be on that. So in conclusions, ton of information I tried to throw at you in a short time. Diverticulitis is an uncommon manifestation of a common condition, and the incidence of both have increased. The CT scan is invaluable, I find, in decision-making, but it's not, free air is not the sole indication for urgent surgery. Initial non-operative management is safe and effective. And when you have an abscess, always place a percutaneous drain when it's 3 centimeters or greater and you're able to. The age and number of episodes should not drive the decision for elective sigmoidectomy. Surgery should be performed on patients when they have uncomplicated diverticulitis. Remember, you need to individualize that decision. If you have complicated diverticulitis, if it's an obstruction, fistulas, peritonitis-free perforation, obviously those patients are getting surgery. If it's an abscess, after a percutaneous drainage and antibiotics, most can be operated on within 6 weeks, but it's important to remember not all abscesses are created equal. If you have a small pericolonic abscess that did not need percutaneous drainage, it may be reasonable, depending on your patient, to not do a plan for an elective surgery, at least initially in that patient. And finally, some of the controversies we talked about. If you're doing an urgent surgical resection for diverticulitis, consider a primary anastomosis with or without a diverting loop ileostomy. Antibiotics are not needed for uncomplicated diverticulitis. Laparoscopic lavage has little role in management of these patients, if any. Complicated diverticulitis in immunocompromised patients warrants elective surgery if possible. And that's about it. Thank you so much for the honor and privilege of talking to you all. And if any questions have come up, I'm happy to address.
Awesome. Great talk. Thank you so much. I personally have a couple of questions. So, what would prompt you to first attempt like a hand assist laparoscopic surgery in a patient with, somebody who may need urgent surgery as opposed to just kind of starting as an open? Because I feel like if you started with a hand assist with a fan and steel, you may be a little handicapped in extending that into a midline incision.
Yeah, it's a great point. It is a great point. And I will say one thing, I didn't have my, you should take this with a grain of salt. I didn't have my, um, whatchamacallit, disclosures in the beginning. And so I do some teaching for Applied Medical, who makes the hand assist port. So take that with a grain of salt. But I did it where I trained at WashU, where, as you know, there's a lot of hand assist surgery that is done. And you're right, we do try to do that gel port as as a fan and steel incision because it decreases the hernia rate. It's more cosmetic. However, you can also do that gel port as a low midline incision. So if there is a patient, if I'm pretty sure, and as I've gotten more experience, I've gotten more and more bold and have known that I can get through most of these patients with a fan still. So I still do that. But you're right. If you start with a fan still and you have to open, making that anchor or that T incision is difficult to close and morbid for the patient. So if you're unsure, if I'm unsure that I'm going to be able to complete it or worried that I may have to open, I'll start with it as a lower midline incision for that gel port, for that hand assist. And then that way you can just extend it straight up into an open surgery if it's not possible.
So maybe early in practice, kind of start with a lower midline with the hand
For
assist.
sure. That's exactly what I did when I started out. For me, it's an 8 centimeter incision, regardless of which direction, but I'll take it right down from the pubic symphysis up 8 centimeters. And then if you can even just, you peek and you kind of look around, if everything's stuck in plaster, you're like, this ain't happening. Then you just open it straight up and you make a big incision. But if it is, you can get in, you can do a little work. Maybe you'll start a little bit and then decide, this still isn't working. And then you open and do a bigger incision.
Okay. And then actually another question I had, but you already kind of answered is when would you attempt to do a primary anastomosis with a diverting loop versus a Hartman's? But I feel like
Yeah.
you covered that, which is great.
Yeah, I think,
What?
again, I think it also depends on how comfortable the surgeon is, right? And so for me, for now, unless it's like a bomb everywhere and like the rectum, you staple across the rectum and the staples are falling apart, and it's just everything's like wet tissue paper. That's not the appropriate patient to be doing a prior anastomosis with a diverting loop ileostomy. But if you have a patient where things are stable, anyone that I can, I'll put them together and do a diverting loop because the second operation is so much easier. Yes, you probably have a little bit more issues in the short term managing an ileostomy than a colostomy, but you get rid of it. You can get rid of it, as soon as 2 months after. Admittedly, most of my patients probably are done at 3 months, but you can get rid of it quicker, and then it's an easier second time operation. You can usually do it locally.
Absolutely.
We have a couple of comments from the chat. Dr. Walker said, great talk, Dr. Rosen. Thanks for the info. Dr. Hachim said, how often are you getting the specimen through the rectum? I think that's in reference to a NOTES procedure.
Yeah, or the NICE procedure. Yeah, like
The
a
NICE, yeah. Yep,
natural resection. I'm doing that personally 0% of the time. My natural orifice removals. There is, Dr. Eric Haas is the one who's really talked a lot about the NICE procedure and does a great job with it. The time it's kind of come into my practice and natural orifice resection is if I have another reason. So if I'm doing like an en bloc hysterectomy for cancer and there's going to be a vaginotomy anyway, I'll remove specimens that way. But otherwise, typically not. And so for these urgent surgeries too, if I'm doing a minimally invasive, it's most of the time it's hand assist. So I have an 8 centimeter incision that I can bring the specimen out anyway. So for me, in diverticulitis disease, doesn't really come too much into play.
Dr. Mandugiano asked stents versus no stents for both kind of elective, semi-elective, and or urgent operations. What's kind of your take there?
Yeah, great question. So we do know most of the data on ureteral stents or ureteral catheters is old, and the data kind of shows that what we know is that it does reduce, it doesn't reduce the rate of injury, but it increases the rate of recognizing it. So when you have a ureteral injury, it's of a huge benefit to the patient and reduces the morbidity if you can recognize it while in the operating room. So for me, my decision for ureteral catheters is based on the CT scan largely. I use them a lot more earlier in my practice. I think most people do. You usually get more comfortable with the planes and skilled as time goes on. And so if there's a lot of inflammation, I can track that ureter down coming from the kidney and it's plastered right to where there's a lot of inflammation. I probably would consider ureteral catheters in that patient. But for the most part, I typically am not using them. And I know a lot of my colleagues have, especially if they're doing this robotic fashion, you can do slick things like inject them with ICG and use Firefly to light up the ureters, or there's lighted stents that are made, things like that. And so I think it really is whatever you're most comfortable with. What I tell, so for all you fellows that are listening, in the beginning of your practice, right? There's a lot of this data is great in talking about primary anastomosis and diverting and stuff like that. But what I will tell you guys is early in your practice, you might want to consider being a little bit more conservative about things, right? Doing more Hartmans and doing what you think is safe for the patient, because you want to establish yourself as a safe surgeon, because you're going to be looking for referrals and establishing yourself in your practice. So you want to establish yourself as a safe surgeon. You want to be kind of a cowboy or cowgirl coming out the gate. So use stents, make ostomies, and do what's safe for the patient. And then in terms of what I tell everybody is when we deal with patients, there are some patients that come in that have a real desire to of how you're going to do the operation, robotic, laparoscopic, a transanal, endoscopic, but rarely. That's I think for the most part, that's the rare occasion. Most patients just want to be not sick and want to not die. So it's really important to know your own technique the best. If you're best a robotic surgeon, do it robotically. If you're best as laparoscopic, do it laparoscopic. You're best at hand assist, do that. If you're best at open, we know as you go forward, you should have some kind of minimally invasive approach that you should be skilled in to be able to offer patients, because we know the benefits of minimally invasive surgery. But be honest with yourself and your own techniques and do whatever's best for the patient in your hands.
That's some pretty sound advice. Dr. Modi was also going to ask, what makes you decide whether to divert when you're doing a semi-elective case versus an elective case where the tissue is kind of suboptimal, like the rectum is very thick, or they have a colovesicular or colovaginal fistula?
Yeah, great question. So a lot of those intraoperative decision makings are more subjective. So we kind of talk about, if both ends are terrible and mush, then you do a Hartman's. If one end is terrible, you put them together and divert. Typically for most elective diverticulitis, the vast majority, you can get down to upper or mid rectum where it's soft and pliable, and I'll feel comfortable doing a primary anastomosis. Now, all of those patients, and the presence of a fistula doesn't necessarily make me more or less likely to do a proximal diversion, provided that fistula hasn't caused like mush and terrible tissue that's like a bomb in the pelvis. But obviously on every anastomosis, I'm doing an air leak test, right? So when you're doing the principles of anastomoses are kind of the same. You want it to be well perfused. So I'm doing a marginal artery perfusion test. Usually I'm doing that by flashing the marginal. If I'm doing an intracorporeal anastomosis, then usually I'm using ICG as a basis to look at it. But some type of blood perfusion test. You want to make sure it's tension free. You want to make sure that it is well sealed. And the way I do that is by clamping proximally and doing an air leak test it's flexible sigmoidoscopy with carbon dioxide. And it's submerging that underwater, making sure there's no bubbles. And also what I really like to do is for that end-to-end however you're doing your colorectal anastomosis, you're doing end-to-end, you're doing a Baker style, however you do it. I think really seeing that really perfect ring endoscopically on a flexible sigmoidoscopy is really satisfying to know that, all right, there's no gaps, there's no defects here. And of course, you're checking your donuts too to make sure those are complete. But those can be tricky and can fall apart as you're pulling them out, and not exactly the most reliable. So I rely the most probably on the air leak test, on seeing a real nice ring and also make sure no bubbles leaking out.
When you're putting somebody together, either electively or urgently, and you have kind of a soft and pliable colon, but filled with large diverticulum, do you ever feel like a Baker it's easier to do because the diverticulum kind of span on the like either side, and they leave kind of the tinea free for the Baker?
Yeah, good question. Yes, the short answer, that's a totally reasonable place to go, because we know that we talked about the distal aspect of resection being down where the tinea splay out, making sure you're on the rectum. Proximally, we tend to go where the colon is soft and pliable. And I'll admit, sometimes it's so full of diverticulum, I'm like, how can I even make an anastomosis here? These ticks are going to be in the anastomosis. And I'll take a little bit more just to get to a little area where there's a little fewer. A Baker, I think, really where it really shines is when you have some degree of colonic dilation too, and just it'd be really hard to shrink that down around doing a purse string around the end-to-end anastomosis. So that's when I think a Baker is a great option. Also, similarly, as to your point, if you find like, oh, this anti-mesenteric tinea has like no diverticulum, this is the only spot. Yeah, that's a great time to do a Baker instead of a end-to-end if you think there's going to be diverticulum. When I do my purse string, I do a hand-sewn purse string and tie it down. And then I clear off all the mesentery and I make sure that exact thing, that there aren't any ticks right around the circle of the anvil that's going to be drawn into the anastomosis. And if there are, I'll do an extra little purse string. Usually I'll use like a 3/0 vicryl. I'll put it right through that diverticula and then I'll tie it on the other side of the anvil. And that draws that diverticula, that portion of it. So it'll be within the donut that gets cut out. So it won't actually be within the anastomosis. Now, to your point, if there's ticks everywhere, you kind of just got to figure it out. But sometimes if I get one I'm like, oh, that one's going to be right where I don't want it, then I'll do a move like that.
Okay, great.
And then we had one more follow-up question before we wrap up. In terms of along the lines of extraction sites for high-risk patients, like high BMIs, immunosuppressed folks that you're worried about surgical site infections, do you still do fan and steels, or do you prefer like a left lower quadrant incision to stay away from the pannus? And then do you decompress the rectal stump?
So I presume this is talking about elective resections, I think is probably what it
Correct.
sounds like. And decompress the rectal stump, I mean, like leaving a rectal tube in postoperatively, I think is probably
Yeah, after Hartman's.
I don't routinely do that. Oh, for Hartman's procedure?
Correct.
For Hartman's procedure, if the rectum is very dilated and it's done emergently and like full of, even if it's just full of air, yeah, I will leave a rectal tube in I'll just suture one in, leave that for a few days just because I don't want it to blow out the rectal stump. 3 to 5 days, somewhere in that, basically as long as the patient can tolerate it, because everybody hates it and like asks for it out immediately. In terms of, and that was the second part of the question. The first part was, what was it again?
You usually like favor fan.
Yeah. So you can, so great question. So yes, when that pannus you have a big pannus and it's hanging down and it's on your hand, if you have the fan and steel, what you can do then is with a big pannus, a couple things. One, if I'm doing this still, so if I'm doing it straight laparoscopic or robotic, then those things, I will extract those off midline. Usually wherever I make my 12-millimeter port for the stapler, whether it's an endoscopic stapler versus a robotic stapler, I'll end up extending that incision since I have to close that one anyway. So that'd be for a right lower quadrant if it's robotic, or usually right mid-abdomen if it's laparoscopic, but somewhere over there I'll extend that. And then so I'll staple minimally invasive, bring out the straight end through that. I'll make a wound protector, enlarge that incision, make a wound protector. And you can tie off that wound protector when you drop back into re-insufflate for your anastomosis. So yes, I'll do an off midline. And then if I'm planning a hand assist, I will still plan for a fan and steel type incision. But typically I'll do a fan and steel if there's not a big pannus 2 centimeters or 2 finger breadths above the pubic symphysis. But in those patients, sometimes the pannus is hanging down lower than the pubic symphysis. So what I'll do is I'll judge where the pubic symphysis is, and then I'll actually make my fan and steel, and sometimes up like near their belly button. And it's still a transverse incision, but I'll do it so that I'm going straight down above pubic symphysis. And usually that'll get me through the case without the pannus hanging down on my hand and causing that issue. And that's a way you can get around that.
All right. Awesome. Thank you so much for the talk.
Absolutely. Thanks for having me. This was great. A lot of fun.
Yeah.
Have a good evening.
Take care, everyone.